and weight. I know some people continue to trickle in, but I want to just welcome everyone to this extremely important topic. I'm Sarah Adams. I'm a pediatrician at Akron Children's Hospital, and I'm grateful to the Ohio Department of Health, as well as the Ohio Academy of Pediatrics, the AAP Ohio chapter, for this amazing program. But most importantly, we are grateful to have speakers today from the Emily program. So let me tell you a little bit about the Emily program. It is a national leader in the treatment and recovery eating disorders, and they offer outpatient, IOP, PHP, and residential levels of care for all genders starting at the age of 10 plus. They're a multidisciplinary team of therapists, dietitians, medical and psychiatric staff as well, and they're located in Columbus and Cleveland, but can provide telehealth services across the state of Ohio. So if you're worried about someone and their relationship with food, body image, or exercise, we want to encourage you to reach out. And we are so thrilled to be able to learn more about the program. Today, we have two people from the Emily program. Our main speaker today will be Nicole Raleigh, RDLD. Thank you so much for being here. And her coworker, Caitlin Perk, will also be here for support and to discuss any questions and resources that we need to clarify. So at this point, without further ado, I'd like to turn the program over to Nicole, and she's going to tell us a little bit more about herself. And I hope everyone enjoys the program. As always, if you have any questions, Alex from the Ohio AAP will also, and myself will also be monitoring the chat box, and you'll have plenty of opportunity throughout the program to ask questions for either Nicole or Caitlin. So thank you again, and Nicole, take it away.
Yeah, thanks so much, Dr. Adams, for that introduction. Hi, everybody. I'm Nicole. I'm really excited to spend the next hour or so with you all and talk about something so near and dear and close to my heart. I started working for the Emily program in July of 2020, and adolescents have always been a big focus of mine and a big part of my heart. I'm a triplet, and my sister was diagnosed with AN when we were 16, so around the age group that I work with now. And pediatricians and our family doctor was actually a really big part of that process and getting her the help that she needed. And so I'm excited to talk with you guys today and share a little bit of the knowledge that I've gathered over the last few years of specializing in adolescents and family in the world of eating disorders. As Dr. Adams said, I really love questions. I think it's super helpful to helping understand information when we're learning it. And so please, please, please feel free to ask anything or comment as we go along if there's something that resonates with you or that you just feel would be helpful to share. I would love to see it in the chat. Okay. So there we go. Okay, to start, I have no disclosures. Moving on. So our agenda for today, I kind of broken down our discussion into four sections. So we're gonna start with a eating disorder basics overview, which really to me means we're gonna do a little bit of the science and talk a little bit about what we know with the research that we've gathered in recent years with eating disorders. We're gonna talk about weight and the 9 truths of weight and weight stigma, which is from the Academy of Eating Disorders. We're going to talk about how we approach nutrition support and what might be helpful if you are talking with clients of your own about nutrition, and then referrals and ongoing onward support that would be helpful for you all. Okay, to start, getting into the fun stuff. The types of eating disorders and some of the basics that will be helpful for y'all to know when we are talking about this over the next little bit of time. So there are a couple of different types of eating disorders laid out on the screen in front of you. Anorexia nervosa, also sometimes labeled AN, bulimia nervosa, BN, binge eating disorder, BED, avoidant restrictive food intake disorder, which stands for ARFID, other specified feeding or eating disorder, OSFED, and then unspecified feeding or eating disorder. What is important to note about these subtypes and these different diagnoses of eating disorders is that one, all are important to treat, and two, all are the same in severity level that we approach in treatment here. So what that means for us more on like the smaller level, I guess, is that I think that it's really common for just AN to be like the typical eating disorder that we talk about in the media or that we look at. And it's really important to me and to our providers that we think about all of the different types of eating disorders. So we'll actually start on the right with ARFID and OSFED. ARFID is still technically considered a restrictive intake disorder. ARFID is really the kids that we think about who are those really picky eaters, like all the way from childhood. There are 3 subtypes of ARFID, which are really fascinating to me, and those are sensory sensitivity, fear of avoided consequences or fear of adverse consequences, excuse me, and then lack of interest in eating. What that kind of means is that not every, super picky eater is going to fall into the sensory sensitivity category. That also means that there are some kids who have a fear of choking or have a fear of an allergic reaction, and they would also fall into the ARFID category with that fear of adverse consequences. Lack of interest in eating is less common that we see in ARFID, and it is kind of those kiddos that if you guys have ever met one that are just like have no interest in eating, they have no interest in getting a meal, they kind of have a disgust response when it comes to meal times, those would fall into the 3rd subtype of ARFID. OSFED is important to point out for the subtype that is underlined atypical AN and BN. Thankfully, the DSM-5 has updated their diagnoses in the last few years, which is great, which now means that atypical AN and BN fall under this category. And that means that clients who exhibit signs and symptoms of anorexia or bulimia, but might not have the weight criteria that used to be under AN, now can get an atypical AN diagnosis, which means that clients in larger bodies or kiddos in larger bodies who have all of the traditional restrictive intakes, fear of weight gain, etc., would still qualify for this diagnosis. And similar with bulimia as well. Moving on to the left side of the category, a couple of things just to point out that are important for me is under AN, you'll see that I've underlined or failure to meet growth trajectories. So typically when we think about AN in like the media, clients will tell me like, oh, I didn't think that I had an eating disorder, especially for a kid, because I didn't lose any weight. And really, we know that it's important to think about for kiddos, they should be gaining weight and continuing to grow through, birth all the way up through their young adult years, like age 20-ish. And so when a kiddo is not gaining weight, they are also failing to meet their growth trajectories that will be common or typical for them at that age group. So that could put them in that category for AN as well. And then bulimia, similar to what you would think of under this diagnosis, usually binge eating followed by a purging of some sort. That can be vomiting, but we also like to say that that could be laxatives, that could be diuretics, and that could be overexercise as well. So any way that a client kind of rids themselves of that guilt and shame that comes following an intake of food. So how do people get eating disorders? This is my favorite graph to show to parents as well, to kind of like demonstrate to them kind of what happens. Because a lot of parents will say to me like, Nicole, how did my kid get here? Like a couple of years ago, they were fine, they were great, they didn't have any problems with food. And I say, yep, like that's kind of how that works. So I usually bring my hands out and I go like this and I think about a triangle. And most clients or most kids that have eating disorders have a 3-pronged kind of approach to how an eating disorder would develop. So the top one would be biology. And this is really rooted in genetics and epigenetics, which means that eating disorders are a brain-based illness. And so if it is in the family history, if a sibling, if another family member had an eating disorder, that is rooted in their genetic code as a child when they are born. Similar to how red hair, blue eyes are passed down, same with mental health disorders. Second side would be experience and traits. So this would be things like trauma or anxiety or depression, substance use, self-harm, etc. these obviously are not born into the brain, and they happen as a client or a child kind of progresses throughout life. And then the third one that's really important for us to talk about is environmental. This means specifically teenagers and specifically adolescents are in an environment that can trigger these two other things to form together to form an eating disorder, kind of like the perfect storm, we call it. So that might be being weighed in gym class, right? An environmental trigger. That might be social media pressure or presence that is influencing the way that they might think. That might be in a comment at, the Thanksgiving Day table about how much is on their plate. So when all three of these things come together and line up perfectly, that's when the eating disorder develops. Some kids have the genetic code and the anxiety forever in their brains, but they never hit that environmental trigger to get them to that eating disorder or to those diagnosis. And sometimes they do. And so we'd like to kind of take that off of parents' shoulders and say, this wasn't anything that you did, this wasn't anything that was your fault, and this is kind of what we know about the science of it all. Signs and symptoms. I really like this picture on the bottom right. I'm a visual learner, and so seeing pictures really help me kind of connect what I'm thinking about to what is going on. And so some of the things that they point out down here is more potential signs of an eating disorder. So they mention things like excessive exercise, preoccupation with feeling fat, abnormal electrolyte levels, intense fear of gaining weight, and usually large intake of food or anxiety or avoidance around eating. Most important thing here to think about, and that parents actually really resonate with over time, is that we talk a lot about isolation and emotional reactions during food and meal times. So we know that eating disorders thrive most successfully in isolation. This means that when kids are in their rooms, when parents are kind of checked out from what's going on in their lives, when they're out of the house a lot, maybe they're with friends more and frequently, that's really where the eating disorder is able to use behaviors most successfully. Because a lot of these kids, and we're going to talk about this in the next slide, are hiding so much beneath the surface that if they were asked to be around people more frequently, those things that are being shoved down are going to have to kind of bubble up to the surface and come out and be shown. So parents will say to me things like, Nicole, my kid just started like sleeping so much more, or they started like not wanting to play soccer and they've always loved to play soccer, or they never came to family dinner anymore. And I say, yeah, like those are really good symptoms and signs that maybe something else was going on there, which is so hard because that's also being a teenager. Well, you got to find the balance of the in between there a little bit. Other things to point out here before I move on is in the physical. I think it's always interesting to point out what happens in the GI tract when we have an eating disorder. So a lot of kids are present to pediatricians or to family doctors or to even GI to consult about their disruption in their dysregulation and their hunger and fullness or bloating or constipation, etc. And we know that a lot of times when they do have an underlying eating disorder, their GI tract is going to be really dysregulated and not functioning correctly because the stomach is a muscle. And when it's not practicing breaking down food regularly, bloating, discomfort, gas, etc., even reflux, all are symptoms that can start to come and arise. So if you're seeing a kiddo who is, never had a problem with dairy, never had a problem with gluten, all of a sudden it's like, every time I eat anything, I'm bloated, I'm distressed, I'm vomiting, I'm nauseous, etc. That could be something to pay attention to. Okay. I really love this picture. Again, I love pictures. I'm a visual learner. But we show this a lot to talk a little bit about the challenge of screening for an eating disorder. And so I want to validate the challenge that can come with interacting with kiddos that have disordered eating or eating disorders because of kind of the complexity of that. And so what this picture kind of demonstrates is it's an iceberg, and we talk about how the physical signs and symptoms and the physical behaviors that you're seeing from your kid, aka that isolation, that disruption kind of in mood, etc., is only the surface of what is actually going on. And that mental preoccupation with food is everything that's beneath the surface. A lot of times I'll talk to kids in my assessment and I'll say, how much of the day do you spend thinking about what you're going to eat next, how you're going to eat it, where you're going to get rid of it, how you're going to hide it, how much it's going to count for, what the calories are, how much you're going to have to exercise, like whatever, etc. If your clothes are going to fit after, like we go through that, and they're like all day. I think about it from the morning I wake up until when I go to bed. And that's like the preoccupation. It's just spinning and spinning and spinning and spinning and spinning from sun up to sundown. And that's everything that's kind of going on underneath the surface. And adolescents are really smart. They know that if all that underneath the surface kind of bubbles up, then that is going to be something that they're going to need to address, usually within treatment. And so they have this like almost phobic fear of letting people kind of understand what's going on in their brains, because they don't want to present like they have an eating disorder, or they might not want other people to totally understand or recognize what's going on for them. Other things to think about that I find very interesting is we think about the brain, right? So the eating disorders are a brain-based illness. And there's some research to point out that brains, especially adolescent brains, have some kind of common traits that tie into other specific eating disorders. So we've pointed out a few here on the left, which is harm avoidance and anorexia, negative urgency and bulimia, anxiety, altered reward perception, and then a couple others, hypervigilance, attention to detail, perfectionism, harm avoidance, risk-taking. Why we point this out is because really what's underneath this picture is in adolescence, an increase in hormones during that growth and development makes teens more at risk for using maladaptive coping skills of an eating disorder. So I always think about like teenagers who really maybe are like in that altered reward perception. So people with bulimia, for example, like those risk takers, those people who like to feel really big emotions, those kiddos that like make judgments that might not be the best for them, they have that like high reward response, and they might fall or might be more perceptive, or they might be more likely to develop bulimia because of that reward response that comes with that behavior. So when we have really high hormones that make things feel out of control, that make us question our bodies, that make us uncertain of what life is, harm avoidance, negative urgency, altered reward perception might be a way that they choose to cope with how they're feeling. Okay, average onset for eating disorders. This is from some research from the Emily program, and what we've seen with the age that we're seeing clients. I think it's fascinating to point out, obviously, the two categories that are the largest, 11 to 15 and then 16 to 20. And I think I might talk about this on the next slide. Yes, I do. So approximately 50% of adolescents who meet full criteria for one of the eating disorders have never talked to their concerns despite having contact with a healthcare provider. And so I think that's really interesting that most of those kids between 11 to 15 and then 16 to 20 are going to yearly well child checkups. They're in college, they're in the health and wellness studio or whatever that's called at their local university. And so it's so important that we are assessing for this, because that is where we're really going to be able to catch this development of eating disorders in that really high risk time that we have kiddos developing eating disorders. Okay, Alex, I'm going to pause for a second. Are there any questions from that first section before I go on?
This is Sarah. I have a question. When it comes to fear of adverse consequences,
Mhm.
what is there a time frame that a patient has to fit in, have those fears of consequences before it becomes a diagnosis? Like, for example, I've had patients who maybe had choked on something and
Mhm.
then they were afraid of eating for 2 to 4 weeks or
Mhm.
maybe less, maybe a little longer. But when it comes down to when we actually need to refer in that, I mean, I would imagine losing weight and so on, but in the criteria, is there a length of time that we really have to look at when it comes to that?
Mhm. That's a great question, Dr. Adams. No, there's not a length of time that we're seeing that I would say like at 4 weeks, like you have to refer. I would say you're spot on with really monitoring more like what the intake is looking like and how severe that kind of like downfall is, right? So if they're fearful of it and they can kind of, work through that in outpatient or with parents of, okay, like we're gonna continue to eat, etc. Their weight remains stable, all other vital signs remain stable. I would say that that's appropriate to just continuing to work through and give them experiences of where choking is not happening. Um, I would say if other things kind of start to come to play, like, we're cutting out foods. Most of our kiddos that we see who have that fear of adverse reactions um, will then not want to eat anything. So, like, if they're decreasing their variety, if they're not taking in the same volume, if their weight starts to drop, that's when I would say would be a good time to refer. Does that answer your question?
Yes, absolutely. And Dr. Zamudo in the chat, Zamuda, sorry, mentioned, we're terrible about identifying them and weight bias is at the heart of that. I completely agree. But her
Mhm.
question is, what is the risk of those with AFRID, those kids who have no interest in food later, developing EDs like anorexia, for example?
Yeah, great question. We There's no real research to prove this. This is more of just my observation. A lot of our kids who have ARFID have some like twinges of AN down the line. So what we know about that is that both are restrictive eating disorders, and when the brain is malnourished, they can present very differently at first, and then as we start to renourish, some like of the different eating disorders, maybe that sensory issue or maybe that lack of interest starts to kind of morph into AN down the road. What is true about ARFID and how we can kind of really suss that out is that clients who have like true 100% ARFID have no body image distress associated with their diagnosis. So if a kiddo is starting to weight restore, and actually this is true in the ARFID that I've worked with, is that a lot of the ARFID kiddos like want to weight restore because they've always been small, they've always not taken in enough food that they've needed to, and they're like, I don't want to look like a 9-year-old when all my classmates look like they're 14, 15, 16. And so usually for our kiddos that have that kind of like interwebbed diagnosis, as they start to weight restore, some of that like body image distress starts to kick on and we can start to poke at that too. So yeah, great question. Anything else, Dr. Adams?
Dr. Zamuda says thanks. And yeah, I think we're ready to continue on.
Okay, beautiful. So talking a little bit about weight and weight stigma. I'm not going to go through this whole document, but for those who are interested in looking at it, I always have it hanging up in my office. And I always encourage providers to look at it and print it out if you feel comfortable doing so and hanging it up as well. It's from the Academy of Eating Disorders. It's like an amazing document for parents and it's an amazing document for healthcare providers as well. It really talks about how weight is multifaceted and where weight stigma kind of lies within eating disorders. So if you just Google the 9 truths of weights and weight stigma, it comes up super easy. It's a PDF and it's really easy to print and share. So main points from today that I want to talk about with weight and weight stigma, and then we're going to look at a few growth charts together and kind of, I'll share my perspective on how we approach goal weight and weight within eating disorder treatment, is diets for kids are really harmful and really unsafe for specifically adolescents that we're talking about today. We know that weight loss at any point in time for an adolescent drastically increases their risk for the development of an eating disorder, mainly because of what is going on, again, in the brain while adolescents are developing. They have so much going on up there that losing weight and becoming malnourished, no matter what weight that we're at, really affects the way that kiddos are able to cope, and therefore kind of turning to, like I said before, those maladaptive coping skills like eating disorders. BMI nor percent of ideal body weight are really useful clinical tools in talking about with kids. We know that BMI is really, we would say, like the best tool that we have right now to talk about weight, and it's super inaccurate for children. We talk a lot more about BMI Z-score for kiddos, and if anyone has questions about that, we can bring that up at the end as well. But when we're talking about weight with kiddos, BMI was not designed for them, and we want to be really mindful that that can be a really harmful conversation to be having with kids at this age. My last bullet point down here is from the book Sick Enough, with Dr. Gudiani. She's an amazing practitioner and doctor in the field of eating disorders, and she talks a lot about how it's really normal for girls to gain and develop about 30 pounds in adolescence, and this can happen gradually or rapidly depending on specific growth patterns. And oftentimes no one tells teenagers or girls specifically how normal this is. And we know that eating disorders developing between the ages of 11 and 14, when puberty is most happening, happen because girls are starting to gain weight and fit into their young adult bodies, and they think that they're wrong for developing this weight and maybe having it first appear more in their midsection before it distributes. And that's really triggering to girls. And so we try really hard to normalize this conversation for them that, oh my God, this is so normal, that your body is doing exactly what she needs to do, and that you are not wrong and you do not need to change your body for growing and doing exactly what your body has done all along. So looking at some growth charts here, I've found that, well, let me back up for a second. So growth charts are what we consider the gold standard in setting what we would call a goal weight with a kiddo in eating disorder treatment. We use this because it is historical data, and it's also data that kind of will show to parents what we're looking at when we're talking about goal weight. So some factors to consider, I wrote up here, when we're talking about goal weight and weight restoration: patient's height, their childhood growth charts, pre-eating disorder weight if applicable, familial body type, menstrual cycle, sex drive, and hormone functioning. So looking at this chart right here, this is an amazing growth chart, I'll just say. For the first part, most of our kiddos don't have this much data. This pediatrician was on it and had all the data points to give to us, which was awesome. So if you're looking at the bottom where we're looking at weight, you'll see that this kiddo, she had really strong data for most of her adolescence. She came to us right around her, I don't even know what age that is because I cut it off. I think that she was 15 or 16 when she came to us. And you'll see kind of in that red zone that I pointed out where her weight fell to when she admitted to us. So when I'm looking at this growth curve, I'm seeing a couple of different things. One, really strong growth all the way from 2 to when she admitted to us. I'm seeing what I'm guessing is where she hit puberty, which would be right around that middle point where her weight kind of went up from the 50th percentile closer to the 75th. That should be around like 12-ish. And then started to track up above the 75th percentile for after puberty. Something that we see quite a bit of in our growth charts that we see with our kiddos is this idea that most of our girls specifically are 1 percentile pre-puberty, and then they are another percentile post-puberty. So for this kiddo in particular, she was trending closer to like the 50th, the 60th percentile. And then after menstruation, she started trending up closer to like the 75th or the 80th percentile. I will be completely honest, and I have no research to back this up other than all the growth charts I have seen in my years of working with adolescents. And we're still looking at why that happens, like why it's such a large jump up. And nonetheless, she was following her curve, right? From when she was 2 up to when she started developing an eating disorder. What I like to show to parents and talk about when setting goal weights is what I call the red zone. So that's why I have that little red circle there. And because eating disorders are brain-based illnesses, we talk about it a lot in the way that for this kiddo in particular, when we're thinking about goal weight, is that yes, like according to typical BMI patterns and according to typical weight, she was, when she admitted to us, around 115, 110 pounds. And while that doesn't sound like something that would feel like she went down to like 60 pounds or something that, you know, when you hear that weight, you're like, oh my God, that's so small. Like she definitely has AN. For this kiddo in particular, that is significantly off where she should have been at 16, 17 years old. So because she was a 75th percentile-ish baby or young adult, her weight should have been closer to 150 pounds when she was growing appropriately on her curve. And so falling from 150, 145 pounds all the way down to 110, that range in between there is that red zone. So she was actively using eating disorder behaviors from 145 pounds down to 110. She was actively restricting, she was actively purging, she was actively over-exercising. And so her body thinks that that area in between there is really unsafe. And her brain thinks that it's really unsafe because she wasn't appropriately nourishing or fueling or growing at the rate that she should have at that time. And so while she's weight restoring and while she is nourishing her body back up to really what we would consider a healthy place for her to be, anywhere below where she was before she had eating disorder behaviors, the body is going to think that's still unsafe. And we know that really strongly based on their nervosa, which means the noise that goes on in their brains when we see them eat in treatment. That's the anxiety, that's the compulsion, that's the food rules. Those are the rituals that they present to us when they are nourishing and re-eating. Of that, man, they just feel so unsafe in their body and they just feel so unsafe in their brain. And so it's really important to us that we provide this education not only to parents, but to kids, because oftentimes our clients feel really validated when we say to them, this is why you feel this way, right? Is that your brain is not supposed to be at this weight. Your body is not supposed to be at this weight. And when we set goal weights below what is their trend and what is their historical pattern of growth, they're never going to feel like they are in a place that they can actively do recovery for a long term. And we're setting them up to fail, basically, because their brains and bodies are not there where they need to be. Before I move on to our next one, I have an arrow up above as well, because looking at height can also be an interesting predictor of where eating disorder started if we don't have as many good growth points as this beautiful chart does. But you can see those points that start to kind of level out below the 75th percentile for this kiddo. She, we're unsure if she stunted her growth. She likely did a little bit because of when she got her, because of when her eating disorder started. So she reported it starting a little bit earlier than it actually shows up on her chart. So likely she could have been a little bit taller than she was. And she was already pretty tall when she got to us. So those points over there kind of just show that she was a little bit below where her curve may have been if her eating disorder didn't develop at the age that it did. Okay, growth chart number 2. So another growth chart that is fascinating for us to look at because of the historical data that we have on this kiddo. So as you can see, this kiddo was always above the 97th percentile for her weight. So the earliest data point we have is closer to age 4. I want to say that is, yeah, age 4. So she started trending at age 4 down here, and then all the way up was her curve over here. And then she fell down from around 190 pounds down to 115 when she admitted to us. And as well as her height, she was like always above the 97th percentile, always up here, all the way to the top. This data point is really interesting for me to consider for a couple of different reasons. This kiddo also came from a family of larger bodies. So both mom and dad lived in larger bodies, and she did obviously from 4 up until her eating disorder kind of developed as a teenager. And when we were setting this kiddo's goal weight, there was a lot of discussion about what was appropriate for her because of where her weight had fallen to and where her trend had been historically. And we eventually decided on continuing to allow her to trend up above the 97th percentile, closer to where her weight would have been previously if she never developed an eating disorder, so which would have been closer to around that 200, 210 pounds. And that got a lot of pushback from her family, from other medical providers that we've worked with, etc. And sadly, this kiddo discharged from us before I was able to see her fully reach her goal weight. But yeah, I think that I show this growth chart for the reason being that I always think about if this kiddo was a 5th percentile baby and then she went up to the 50th, there would be no pushback about her goal weight. And it would have been very normal for us to set her right back up at the 50th percentile. But even though we have really strong data from 4, 5, 6, when she wasn't exhibiting any eating disorder behavior, she had very normalized eating patterns of being above the 97th percentile. There was pushback about setting her goal weight back to where she was trending previously. Okay, I think I'm going to pause there. Yes, okay, I'm going to pause there before we move on to nutrition and meal support while being mindful of our time. I think I've got about 1 to 2 more sections left. Anything coming up?
If anyone has any questions, feel free to unmute or put it in the chat box. That's always an option as well.
I have a question, Dr. Adams and Nicole. I think I see this from both lenses. And so I'm curious if you can maybe share some perspective about how you might communicate with the medical team about some of those decisions, because while I completely agree with everything you're saying, I know a lot of my colleagues will say, but I have to look at, health outcomes, and I know that these things matter. And so I could see the slippery slope either way, but I wonder if maybe you could comment on that, because I imagine that's something that a lot of people in this group are thinking about as you're talking.
Yeah, absolutely. Thanks for bringing that up. Yeah, so that is something that we talk about actively on our team, and then with external providers as well when we refer these kiddos, back to their primary care provider to be monitored. And really the way that I look at it is that a lot of these doctors are thinking about future outcomes, right? So we're thinking about future health, they're thinking about future diagnoses that these kiddos might be encountering. And we talk about it as, we know actively right now that this kiddo is battling a very severe eating disorder. We know that they have been diagnosed with a very severe eating disorder. And our job is to treat what they have been diagnosed with right now. And that will be like trying to avoid treating somebody for cancer because they might develop, I don't know, a swallowing disorder, right, in the future. And we're looking at it of, while that is something that might come down the road, their eating disorder could kill them right now. And so we find it important to prep the kid and the parents for, let's focus on what is your child is actively battling right now in this moment. And if things come up down the road, we will address them as a community, as a team, if those needs arise. What are your thoughts on that? Answering your question.
Yeah, it definitely answers the question. And I think, I don't know what background you have on the parenting at mealtime and playtime program, but it totally focuses on developmental feeding and skills and not necessarily the other pieces. And so I think there's a natural relationship there because you're building skills that are then going to apply later in life and hopefully support, health outcomes overall. So no, thank you very much.
Yeah, thanks for the question.
There is another question. Can you speak on the identification and care of a pregnant teen who has an eating disorder, please?
Ooh, man, I might have to think on that one. Yeah, let me think on that. And then I'll get back to it at the end of this. I don't know if I've encountered that a whole bunch. So let me put some knowledge to it and then I'll circle back to it. But thanks for asking.
I would like to mention that the preventative health program through the Ohio AP yesterday had a lecture specifically about how we can care for pregnant teens. So if you're interested in learning more about that, it didn't, it wasn't specifically on nutrition, but it just covered kind of the entire teen, and including support in regards to all aspects of their life. So that should be available on the OHAAP.org website as well.
Beautiful. Thanks, Dr. Adams. Okay, so switching to the Emily program and our nutrition philosophy. So biggest thing to think about, and the biggest thing that we talk about, again, with parents and with kids, is that we take a really neutral approach to food when we're refeeding our kiddos. So we tell them from the get-go, there is no such thing as good or bad food. Because most of them, when they get to us at this point, have a really high shame response associated with the foods that they're eating. And I talk about it a lot with parents, and like, again, that drive of adolescent brain of like, if you tell your kid that they can't drive their car, they can't go out, they can't see their friends, they can't drive their car, what does that make them want to do? And most parents say, well, then they want to drive their car, they want to go out even more, like they're going to push me more. And I say, yeah, like that's the same way that it works with food. When we tell kids that something is bad, or that they can't have something, or that there's power over this specific item or this specific food, that only increases, one, shame response when we have that food, and two, that kind of addiction that this food has this power, or it has this specialty that not all other foods have. And so by teaching kids that we have access to all foods all the time, it helps kind of level out that feeling of, oh, I can only have this at a specific time, and when I have it, I have to have all of it. And it teaches them to normalize their approach to all foods. We talk about and look at feeding and eating as a talk less, do more mentality. And so kids and teenagers, right, we know are big learners. They have questions, and they're observant, and they are listening, and they want to learn from their parents and from their peers. And so when parents ask me, like, Nicole, how can I help teach neutrality to food? We talk about modeling neutrality in themselves. So instead of saying things like, oh, I'm so bad for eating this, or I feel so gross, I need to lose weight, or I'll burn this off later, talking about enjoying that food with your child, or being thankful, for your body that you have that helped birth your child, or talking about how your body is good and practice being kind to them. Children are born natural intuitive eaters, right? They know when to eat as a baby. They know when they're full. They know when to sleep. They know when to go to the bathroom. Similar to food, oftentimes they're taught out of feeling and being those intuitive eaters and kind of numbing their intrinsic connection to food. Our job is to help reteach them to build that natural intuitive messaging about food and being neutral as well with our own eating. Okay, last section here, and then we'll stop for questions at the end. So when to refer outward and to get some support. So if as a clinician, you are thinking even a smidge that you're worried about a client, right? You see their growth chart, you hear them talk about food, you hear it from the parent, whatever, etc. We always want to start our conversations with warmth and non-judgment. So saying something like, or explaining to parents, saying something like, I've seen a change in your behavior during meal times. I'm concerned that eating and food has become challenging for you, and seeing what happens. Approaching it with curiosity and with just wanting to understand what is going on in their brains, to let them start to share maybe a little bit about that iceberg, right, of gun what's below the surface. And then this 6-question SCOFF questionnaire can be super helpful as well for clinicians in identifying eating disorders. So these questions talk about stuff like, do you feel like you've lost control when you're eating? Are you worried about your weight? Do thoughts about body and weight dominate your life? And while these questions are wonderful, I wrote on the top of the slide, ask the questions and then ask again. Because like I said, with the iceberg analogy, especially with adolescents, they're so smart and they know what the answers to these questions should be. And they know that if the answers are yes, then they're going to have to stop engaging in eating disorder behaviors and likely get help. And so we ask and we ask again and we ask again and we ask again and we ask deeper questions to really make sure that we're getting at the root of what we're asking. And then give feedback. So last point on here, if 2 or more of these questions, if surprisingly they answer honestly and they tell you yes to 2 or more of these questions on here, that does indicate a strong presence of disordered eating at least. Often individuals with eating disorders can be challenged to answer honestly. And we want to follow up, even if there's only one question that says yes. So if it's probably an eating disorder, what do we suggest that you do? Due to the biopsychosocial nature of an eating disorder, really a comprehensive assessment is so critical to assessing appropriate intervention. So most of the time kiddos come into us or parents come in, they're like, oh, my kiddo really only needs outpatient treatment. They only need to be seen once a week by a therapist. And really we want to make sure that we're providing that full assessment to determine if that is really what is appropriate for that kiddo. The number one medicine for treatment is simultaneously occurring nutrition and therapy together. And so we can't just talk someone out of poor body image, just like you can't talk somebody out of engaging in eating disorder behaviors. We don't want to ever wait for it to pass, especially with parents. We want to be strong in our language and viewing it as something that could cause irreversible damage and approaching it with the complexity that it really is. So some treatment options that the Emily program offers, for y'all's knowledge, is residential and inpatient, which would be 24/7 care, all the way down to weekly outpatient appointments. So partial hospitalization, IOP, which stands for intensive outpatient, and then outpatient, all serve various levels of care and serve various functions when we're treating an eating disorder. Treatment is really dependent on what that person needs. And specifically with kiddos, family involvement in treatment is almost a non-negotiable, right? Because kiddos are living under their parents' roofs, sometimes for a decade after they get treatment. And we want to make sure that parents are just as involved in understanding of the eating disorder and what's going on that the kid is. Some typical treatment-related questions that come up. Where to start, when, how to refer, et cetera, et cetera. All the questions are answered on this slide. And Caitlin and I both are good resources for if these questions come up, or if you have a specific case that you're thinking about after hearing all this that you're wanting to refer, that we can help answer those on. Really, most of the answers, sadly, is it depends, and it depends on the client, it depends on the situation, it depends on the level of care, it depends on the family situation, it depends on insurance. Most of the time, we can get a kiddo or a client where they need to go appropriately. How to refer. So providers, family members, and patients. So a client does not need a referral in order to get an intake scheduled at the family program, which I think is always like the best, one of the best things that we do. So if you're worried about a client, or if you have somebody in mind, they can always take our quiz on the eating disorder assessment quiz on our website, even to help kind of guide further on if they getting help would be appropriate for them. And they can also call us and schedule an intake. An intake is, again, what is going to determine what level of care they need. And if nothing is needed, then that would be determined as well in that intake. So really, getting an intake is never a bad thing. You are not committing to treatment at that time. That's just kind of to show what our team would think is the best course of action for that individual. And that link right there will help take you to our website. Okay, that's all I got for you guys. Again, my name is Nicole. I'm the adolescent and family eating disorder dietitian at the Columbus outpatient site. I work in the partial hospitalization level of care. And yeah, I'm ready for questions. Thank you all for listening.
Thank you so much. Wow, that was so informative, Nicole, and we really appreciate both you and Caitlin for being here today. There's lots of questions, so let's get to it. From Lisa, she said, do goal weight restoration depend on patient's age? So would your weight restoration goals be the same if this chart was for an 11-year-old versus a 16-year-old?
Great question. They do vary and change based on age. So as a kiddo ages, their goal weight and weight restoration goals are also going to change. Most of the time for us, Lisa, if a kiddo is within 6 months of a birthday, we will consider them like aged up and age them with their goal weight to their next age on their growth chart, in order to like help them catch up to what they might have lost previously, if that makes sense.
Yes, absolutely. And Dr. Zmuda says, I think we should be asking behavioral questions around food, regardless of growth charts or BMI at well checks. I completely agree. Very similar to what we do for sexual activity, smoking, and other high risk factor behaviors. Is there a good short screen tool or approach?
I would say probably that SCOFF questionnaire would be the best thing that we have right now to really assess eating at this point in time. Yeah, to kind of identify like thoughts and feelings around that behavior.
It's
Caitlin.
interesting that you mentioned that, because I know we do, and most providers do a lot of screening around, mental health, whether it's anxiety or depression or and even social determinants of health. It makes one think that that might be another, it definitely sounds like it's a tool that we can utilize as needed, but it does make you think if it's something we should be using more than we are.
Yeah.
Carolyn says, so the pushback was not wanting someone to get to the 97th percentile, more from the patient or medical providers who judged thin for her height as more ideal. So I think what she's saying is, was it something like what you and Caroline, if you want to unmute and explain that question, what I hear you saying is that was the pushback about the percentile itself versus, you know, really getting to an ideal height for weight ratio.
Got it. It was a little bit of both. I am thinking from my understanding of your question, Caroline. So really, this kiddo was really tall. So I think she was like 5'11" when she admitted to us. So she was tall at 16. But the pushback really came from setting a goal weight that would have made her BMI to be considered in the obese category. So because her goal weight would have been closer to 190, 200 pounds, despite her past trending in the 97th percentile, that was the pushback, if that makes sense.
And then Mary asked, you know, now that we're done, you know, with the presentation, if you have any further thoughts about pregnant members with eating disorders.
Yes. Yes. So I was thinking about this, Mary. So my reaction to that is, one is that I want to make sure that we're assessing intake and really understanding nutrient needs, one for a teenager and two for a pregnant teenager. So that is going to be a significant amount of intake that a teenager is going to need, right? Not only as she's still growing, but she's now growing in a child as well. And so I would want to just be really warm and thorough with how I'm addressing what she is eating and how much she is eating. I would say other behaviors like talking about body image or other behaviors like purging or like over-exercise would be things to focus on. And yeah, just kind of like digging into her continued weight gain throughout pregnancy and making sure that that's appropriate for a teen and a pregnant teen as well. Let me know, come off mute if you feel like that is not totally what you're looking for, if you're looking for more direct advice.
And Nicole, I can put some just general information on, it's not specific for adolescent pregnant clients, but we do get this often a lot it's more common for us in our adult population, but we do have specific criteria around making sure that they have an established OBGYN relationship and that we're communicating with that provider as well throughout treatment, along with different psychoeducation that would not be standard to our typical programming, around, possible morning sickness and the nausea and vomiting that can occur from being pregnant. We also have a blog post about it, so I'm just going to stick that in the chat bar. So if that is of interest, feel free to check all of that out. And it's not specific to adolescents, but it is specific to how we handle pregnancy, which I know would alter a little bit given the population, but might be helpful to see that too.
Yeah, thanks, Caitlin. That'd be super helpful. Anything else?
Well, I can't say enough, Nicole and Caitlin, for taking the time to enlighten us about this extremely important topic. And I would also like to encourage everybody to visit the PMP resources that we do have, because we're also about prevention, right? And really establishing from the early ages, even from the moment they're born, those first 1,000 days, we call them, and really establishing a good relationship with food, just like you mentioned, Nicole, that it's not good, it's not bad, it's what it nourishes, how it nourishes us and how it makes us feel. And helping providers help parents with the language that's needed to support them in this. I always say there's 3 things you can't do. You can't make a child eat, sleep, or poop. And so eating is so important, especially for their growth and development. I know we all know this. So thank you again for joining us today. And if anybody has any questions in the future, I'm sure that Nicole and Caitlin would be happy to, don't be afraid to reach out. They'd be happy to answer.
Thanks so much, guys.
And everyone have a great afternoon.
Bye.
Thank you all so much. Have a good day.
Thanks, guys. Bye-bye.